Good morning, November 21st,
Correct.
2024. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. Welcome to our live stream. Our patient is a Floridian. He comes to Duke Spine Institute with chronic back pain and symptoms going into his legs, numbness, tingling, and weakness. He has several discs that are damaged in his lower back, and they are the source of his symptoms. He has bad scoliosis, facet arthropathy, lots of things you could see on the MRI, but it's the discs that we believe are causing all of his symptoms. The scoliosis is bad, and it's not causing symptoms, but it's going to make the surgery harder. So we've got to get into the 5-1, the 4-5 on the right, and the 3-4 on the left. So let's go ahead and get started. He also has a very bad disc at 2-3 on the MRI, but he's not having symptoms up at 2-3. He's only having symptoms at 3-4, 4-5, 5-1. That's why we're just treating those three. We're not doing other discs. All right, I'm going to do some local. Can I proceed? If you have questions, folks, feel free to ask us. In the meantime, while we're getting our patient numbed up and gaining access to the disc, why don't you guys watch our video on the 30 causes of back pain. Little numbing medicine, that's all. Lay still, you're doing great. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic sciatic pain down their legs with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. It's not hitting. Hey, welcome back. It's not hitting anything. It's just tight. It's not released. Move the base north. Are you saying it doesn't wag more than this? Really? Lock it. Is that locked? Shot? All right, because our patient has, yeah, that's good. Our patient has severe scoliosis. The L4-5 disc is really challenging to get to. So I'm going to make an effort to do that. Let's just see what happens here. We're going to take the question in just a moment, but first I need to focus for the second so I can get this done. Shot? No, I think I'm hitting the needle. Shot? Too high. Yeah, I'm going to have to start lower. Shot? Even lower. Shot? I'll take your question in a moment, but I've got to first focus because the scoliosis is so bad. This patient has to have 2 separate incisions on the right side because I cannot get to both discs with one incision like we typically do. At least that's what I'm thinking. So I will take the question. Go ahead. You've just watched our animation, by the way, on the 30 causes of back pain. Those are the 30 causes, but they're not equal causes, by the way. Some are more common than others. I'm hitting the iliac crest. Shot? All right, making some progress now. Got to make it to the back of that disc. Give me a second, folks. Shot? That is a little bit lower than I want to be. Just have to be north a smidgen. Shot? All right, that's north a smidgen. I'm still hitting bone. Let's get an AP. Go ahead, Henry, with a question.
Of course, this question and comment coming from Jerry on Facebook. Question asking, hi, Doc.
Hi,
Jerry in Vietnam. How many times cycles or how long can the saline solution used to cool the laser and flush away the disc fragments be used for? Is it purchased or made at Duke Spine? And comment, it was 2 weeks ago. I am the following post-op. It was great. A trip back to the U.S. Your staff was great. Many special shout out to Louise. Many thanks. God bless.
Oh, Jerry, great to hear from you. Hope you're doing well. The solution we use is saline solution. It's regular sterile saline solution. You can buy it. Most hospitals have it, shot. And that solution we cool in a refrigerator to get the temperature down so it's nice and cool. And then it's used to cool the laser, the energy from the laser. So it is just sterile saline. That's all, you know. Nothing special about it. Easy to get. Not something we make at Duke Spine necessarily. Yeah, so I'm hitting the iliac crest, and it's literally pushing my needle. I'm trying to get to 4-5 shot, and his scoliosis is so bad. It's literally forcing me lateral shot. Medial and medially with the iliac crest, laterally with the facet. This is incredible. Shot. Man. Let's get an AP view. Huh? There's no space. No, what's happened is his twisting has forced my needle laterally, and the iliac crest is pushing my needle medially this way. So the bone here, the hip bone in the back here is pushing the needle that way, but the facet is blocking it and forcing me to go more lateral. Let's see, it's really close. Man, yeah, he has severe scoliosis. Let's see. Oh, we're almost there. That looks better. Shot. Give me an AP. So I had to jiggle the needle a little bit. Jiggle and dance. Let's hope that we're close. Yeah, we're right there. That's actually really good. You guys see that?
Yes, we do.
Show them the whole spine. Jordan, go back. AP. Show them, you know, more of the lumbar. You guys can see how twisted it is. You can see it on the MRI. Shot?
Yes, we do.
Yeah, look at that. You can see the spinous process at the top just totally twisting to the side. Anyway, pretty bad scoliosis for this gentleman. But we're going to hopefully fix his back pain, because his back pain is not up there at the top where the scoliosis is really bad. His back pain is actually down here. So I'm hoping that this is going to be curative for him. Yeah, it's looking better. Yeah, there we go. We're past, I think. Yeah, we're past. We're past. Shot. Question is, am I being forced too lateral? That's going to be the issue. Or am I in the disc? Let's get an AP. So on a scale of 1 to 10, this is a level 10. This is one of the hardest you could possibly do. Let's stay there for a moment. Stay there. I'm going to do a little discogram. I want to make sure both these needles are in the disc. A discogram can be used to test if the disc is painful to the patient, but can also be used to see if you're in the right place. Shot. All right, shot. Luis, you can't put your hand across there. Shot. All right, let's do a lateral. Oh, wait, let's do one more. Yeah, hold on. Let's do the 4-5 shot. I think we're in at 4-5. That looks really good. Look at the size of that tear. Look at that tear at 4-5 on my side here, the right side. It's huge.
Yes, we do.
See that black stuff? That's a tear.
Of course, yeah.
Let's take a look at 5-1. Quick shot. Oh, yeah, we're in the disc. So that's good. We're in the disc at both levels. We want to be in the disc. But look at the crisscross of the needles. That just shows you that because of the scoliosis, right, normally the discs are level, like they're parallel to each other. They're parallel like this. But with this patient, because of the scoliosis, the one disc is oriented like this and the other one is oriented more like that. And so I couldn't get this disc with this approach. I had to come further south to start and go up towards the disc to get in. Made it very hard. All right, but the good news is we're in the disc. That's where we need to be. So I'm going to go on the left side now and get to 3-4. And that is, you could see 3-4 right there. It's got a massive degeneration, end plate sclerosis. The end plates are very dark. They're full of thickened bone. That's from rubbing on each other for so long. I've got to figure out where to go in. It looks like the entry point's going to be a little bit lower, maybe right here. Let's just see if that works. Shot? Yeah, that looks good. Let's go ahead and numb them. So I hope I answered your question, Jerry. But we use cold, refrigerated, sterile saline solution. We've been using it for 19 years. Pretty much everybody that does endoscopic spine surgery uses that saline solution. And ours is cold to cool the laser, so seems to work quite well. All right, heading towards the spine. Remember, because the spine is so rotated, this side, the left side, is going to be back towards us. The right side is further down. So it's kind of like airplaned. Shot? But this is a very difficult case for me, technically. Shot? It is not easy trying to get there. Shot? I can't even feel the facet. Let's get an AP, see where we are. That's a great position though, Jordan. I like where you are there on the lateral view. You've done a nice job of showing me that disc space. Yeah, we're too lateral. So because the spine's rotated so much, I have to come a little bit more medial on my entry point to get to the spine. I was afraid that it would be too lateral. Shot? Any other questions?
Yes, we have a question coming from Pamela on Facebook.
Shot? Hi, Pam. Welcome. I feel the disc. Let's take a look. Hopefully we're in the right spot there. Yes, Pam, we'll take your question.
Asking, I have a rod in my lower back and rod and plates in my neck. Having pain down my legs and back. I have had 6 spine surgeries. They're talking more metal. Can you help me?
Absolutely, Pam. You do not need more metal. We can fix you without metal. 99% of back pain. You watch the video. 30 causes of chronic back pain. 85% of the time, that main cause is the disc, and we fix the disc with this surgery. Look at how twisted this patient's spine is. Look at how degenerated those discs are. We're going to cure his pain without putting metal in his back. You do not need metal. I promise you. The best thing you can do, Pam, do our free MRI review. It's, as I said, free, and you're going to get a diagnosis, what's wrong, and then you'll know exactly what treatment you need. Dr. B, any chance we can do a discogram or not? Think he needs to stay asleep?
I think so. He's very
Fidgety?
right off the table.
All right. Well, I'm gonna see if I can arouse him with this.
Because of he has pretty bad.
He has apnea.
Yes. That's why I'm going up and down anesthesia.
Is that my lateral view there? Oh, I was gonna say, should be further in that needle.
How you doing, my friend? Are you okay? How are you doing? You okay in there?
You having any pain? So the patient is on his belly and he's asleep with propofol sedation, but he doesn't have a tube down his mouth, so he can actually talk to us if he's awake. And I like for them to be awake for the discogram if possible. But as our anesthesiologist pointed out, getting him too awake, he may start moving around on the table and come off the table. We don't want that. So we may just want to keep him asleep. All right. Well, we'll test his discs. He may be too deep. Shot? Boy, that's a big tear. It just poured right out of L4-5. Huh? Yeah. Shot? All right. You can see the dye in the disc.
Yes, we can.
All right. So there's so much scar tissue in that 3-4 disc that the dye is literally sitting in the front half of the disc. Can you show that, Jordan? But we're definitely in the disc. So the discogram can be used as an evocative discogram to evoke a pain response, and if the patient's disc is painful, which these are, I'm sure of it, or the discogram can be used to see how big the tear is and kind of get an idea of the anatomy of the disc herniation or degeneration. How bad is it, you know? And you can see from that 3-4 that there's so much inflammation and scar tissue in there that basically it's not even allowing the dye to come backwards. All right, we're going to get started. And Henry, why don't you show the audience how is it that a disc injury like this patient's disc herniation and degeneration, how do these disc injuries cause so much back pain? What's the mechanism by which that happens?
Copy that.
Disc injuries start with an annular tear. Damaged nucleus, pulposus, herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
And welcome back. We are just placing our first dilator, which is down by the disc at this point, which is why it's a little bit stimulating for the patient. We're going to enter the tear at 5-1, and we're going to repair that first disc. And let's show the audience how we repair these discs. Henry?
Of course.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Shot. Whoa, take that. We don't want to trap that. Let's pull this back a little. All right, welcome back. Yeah, pull it back a little bit. Let me know when you get it back, Shot. All right, let's get the wire out. Don't break it. Don't pull too hard. Still trapped? Yep. All right, hold on. Shot. Try to, let me see. Try to get it out now. Don't break it. There you go. Let's get rid of that. Shot. Very difficult. Very, very, very difficult procedure with this patient. Shot. All right. Good news is I believe we're in 5-1. Let's get the tube in. So we showed you how a disc injury like these 3 discs will cause pain, chronic pain that doesn't go away. It's due to inflammation. And now we showed you as well how the laser surgery fixes that disc to get rid of the pain. Maybe advancing the dilator, we just got to watch it. Shot. Any questions?
Yes, we have a question from Raj on YouTube.
I'll take Raj's question. Let's get that dilator out. I think that's good. Bring it out a little and then let's check it. Yes, Raj, we'll take your question.
Raj said, Doctor, hope you're
Perfect.
good. Asking, if you breathe in and hear a cracking sound, then with some pain, what do you think is going on?
You know, Raj, hard to say, but if you don't have a tumor or fracture, then it could be your facet joints. That's not really how we diagnose problems, though. We need diagnostic imaging, an MRI scan, and an exam. Otherwise, it's just guessing. And we don't treat patients based on guessing. All right, we are in the disc at 5-1. This is one of the painful discs, laser. We're going to bring the laser fiber in just to give you an idea of the size of what we're seeing. That metal thing that you're seeing is the actual tube. And the bottom of the tube is inside the tear. You can see the inflammation, right? You see that red stuff there?
Yes, we do.
That is not supposed to be there, and the blue is not supposed to be here. The fact that the blue dye is here means that this part of the disc is degenerated, and degeneration means that there's an acidic reaction. So the disc is becoming acidic. The nucleus is becoming acidic. All right? The dye will bind to acidic nucleus pulposus. It will not bind to normal nucleus. Normal nucleus is white. The blue dye will not bind to normal nucleus. It only binds to degenerated nucleus. So when you see blue, that means it must be the nucleus pulposus. It must be degenerated. And that's what we would expect to see in this disc that's damaged. Degeneration. The disc is degenerating. The degeneration comes from inflammation. That's what we discovered at Duke Spine. That is the source of degeneration. Inflammation is the source of degeneration. What causes the inflammation? The inflammation is caused by the nucleus pulposus, the blue stuff, being stuck inside the annulus fibrosus, being exposed to the inflammatory system and causing an inflammatory reaction. If you don't have an annular tear, you can't have a herniation. Once you get an annular tear, the nuclear material in the center herniates into the tear. It's seen by your body's vascular system, which is its defense system. It uses the vascular system to transport its army around. The army sees the herniation and attacks it. And that's where you get chronic pain, because the attack is ongoing. It doesn't stop. It never stops until you have this surgery or you have a fusion. All right, any other questions?
At this moment, no current questions.
Why don't we show our audience why you should avoid a microdiscectomy?
Yes.
Many people are recommended to get a microdiscectomy or discectomy by their surgeon. It's an old surgery, highly destructive, very damaging. It's going to ruin your spine. It's going to ruin the normal part of your spine. The goal of the surgery is to go in and get the nerve root unpinched by removing a piece of herniation that's sticking out far, pinching the nerve root. The symptoms people get from a pinched nerve root are leg weakness, leg numbness, tingling in the leg, weakness, numbness, tingling. None of those symptoms are back pain. Discectomy does not fix back pain. So if your symptom is back pain, do not expect the discectomy to fix it. It's going to make it worse. Surgeons do not recommend discectomy for back pain, because we know discectomy will not fix your back pain. Therefore, it's not recommended for back pain. Now, some surgeons will tell patients to have a discectomy done because they see a herniation on the MRI, and the surgeon will recommend a discectomy because that's the only thing they know how to do. Or they'll do a discectomy because they know that the patient will not get better and they'll have to come back and get a fusion next. Most patients don't want a fusion. They're aware that fusions are bad, so they refuse the fusion. So the way the surgeons trick them is to do a discectomy first or a laminectomy. They're both the same procedure that doesn't really work. And the patient will get that procedure, discectomy or laminectomy. During that procedure, the surgeon removes the bone that stabilizes the spine, removes it, and the patient ends up with a weaker spine that falls apart over time, and they get more pain in the back, and then they come in and the surgeon says they need a fusion at that point. And the patient will do it because they're in so much pain. So discectomy and laminectomy are old surgeries. They don't work well. They're bad, but they're still recommended all the time because surgeons don't know anything else to do, and some surgeons just want the patient to get the discectomy so they can do a fusion next. Most of the insurance companies want the patients to have a discectomy before they get a fusion, so the surgeons will do what the insurance companies want, recommend a procedure that doesn't work, and then the patient will have to decide afterwards if they want spinal cord stimulator or fusion or both. But in the end, these treatments don't work. Let's show the audience what a microdiscectomy is and how destructive it is.
Copy that.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. You can see with microdiscectomy, the surgeon has to remove normal bone out of your spine called the lamina. It's called a laminectomy or laminotomy. Two different names, same thing. They're going to remove part of your facet joint. It's called a partial facetectomy. You saw that. They drilled part of your facet joint. Well, the facet joint is a joint that's made out of bone. It holds your spine together. Once you take that facet joint out, your spine just falls apart. So that's what surgeons do. They take out part of the facet. If you look up the code for discectomy, you will see it includes a partial facetectomy. Partial facetectomy. You don't want your facet joint taken out. That's like removing half of your knee joint. What do you think is going to happen? Or half of your hip joint, or half of your shoulder joint. This is a weight-bearing joint. The facet joint is a weight-bearing joint, and when you start taking part of it away, this is getting in my way. When you start taking part of that facet joint away, you're going to have an unstable spine. It's just a matter of time. And that's what the surgeons want, because you're going to come back, you're going to get a fusion at that point. Okay? You're going to get a disc replacement. Now, this is hitting my arm right here. After the bone is removed and the facet is removed, the next thing the surgeon does is they cut your ligamentum flavum. They cut the ligament that holds your spine together out. It's called the ligamentum flavum. You saw that removed. It's just underneath the lamina and the facet. By removing the ligamentum flavum, you're weakening the spine even more. So all of this microdiscectomy and laminectomy surgery, all it does is make your spine weaker so that you have pain, so that you have to come back and get a fusion. Now, Henry,
Yes, sir.
let's show these people what a laminectomy surgery looks like, because that's another common surgery recommended by spine surgeons today. Not at Duke Spine. We don't do laminectomy. We don't recommend laminectomy.
No.
Most patients can be fixed without laminectomy.
Of course.
I'll try that. Welcome back. Laminectomy, even more invasive than discectomy, and does nothing for back pain but make it worse. So if you have back pain, which most people do not get a laminectomy, do not get a discectomy, microdiscectomy. They are dangerous procedures. They don't fix back pain. They only make back pain worse. You're going to be coming back to the doctor. You're going to be getting pain pills. You're going to be getting shots. You're going to be getting stimulators, and then you're going to get another surgery like a fusion. And that's what happens to millions of people every year that undergo laminectomy and discectomy. They end up having to go for more procedures, more pain treatment, and they never get out of pain. Instead, the Duke laser disc repair goes around the facet joint, around the bone, and goes through a whole opening that's already there, straight into the tear and herniation. It's a much better procedure. The technique was first described by Dr. Cambin, Parvis Cambin, an orthopedic spine surgeon from Pittsburgh. He's the one who pioneered this technique. And unfortunately, he only taught a few surgeons how to do it. And probably two of the best surgeons that were his students taught me. And I learned the technique from them. All right, I got to see the front of the spine. There we go. Let's get some num-num. Any questions?
At this moment, no current questions.
All right. We'll just keep working then. Why don't we show our audience the second most common cause of back pain, which is the facet joint.
Of course.
Shot. Shot. Welcome back. You can see that the facet joint is another common cause of back pain. It's the second most common cause of back pain. And shot. The facet joint pain can be fixed very simply without even major surgery. It's done with an outpatient procedure where we actually make a small 4mm incision, go in with our Duke plasma wand, and destroy pain nerves. It's called a rhizotomy procedure, and rhizotomies have been around for a long time in medicine. They are safe. Most surgeons don't do what we do. They do what's called a radiofrequency ablation. The problem with an RFA is that it doesn't really work well and it doesn't last. So if you have facet pain, I would recommend instead of an RFA, you do the Duke plasma rhizotomy shot, which is a much better procedure, and it works and it lasts. The Duke plasma rhizotomy works to eliminate facet pain, and the treatment is permanent. It eliminates facet pain permanently. The RFA does not work, and if it does manage to help a little bit, it is not permanent. It's temporary. We are working on number 4-5 disc, L4-5. He has a degenerated disc, annular tear, pain coming from this disc. We're going to go in and use the laser to clean it up. You can see the incision that we used for 5-1. It's 7mm. I'm stapling it. We're going to put a Band-Aid there. Again, very complicated surgery on this patient because his spine is twisted so badly that the opening that I need to get into has moved away from me, and it's down towards the floor. So we have to really work on our trajectory. You could see I could not do both discs with the same incision. But the good news is we are in the discs, we are cleaning them, getting rid of the herniation. Once again, you see the blue material, which is the degenerated nucleus pulposus. It's the bad stuff. You want to get rid of it. That's what's causing all the inflammation and pain. By removing this nuclear material. We're cleaning the tear, and we're going to get rid of his back pain. It's right here. You see it?
Yes,
Yeah.
we do.
A lot of scar tissue. It's the white stuff around it. How do you get scar tissue? The answer is inflammation. This blue stuff is the nucleus. It causes inflammation in the annular tear. That inflammation causes scar tissue over time. It doesn't happen overnight. It happens over many months and years. So when you see something like this with lots of scar tissue, and especially the calcium, the little calcium deposits, that's the gold stuff right there. You're seeing when the laser hits it, it turns gold. That's calcium. That calcium does not happen overnight. That calcium takes many years for it to form. Many years of inflammation in the disc happening, and then you form calcium. All right. This is the tear. You guys can see the tear right there.
Yes, we do.
And I have to debride the tear. That's what this is, a debridement. Debridement means your surgeon is cleaning out something that is all grungy and bad. Sometimes we do debridements for infections of the skin or wounds. In this case, this is not an infection. This is just inflammation. Any questions?
Yes, we have a question coming from Raj once more on YouTube saying, in your experience, doctor, what is the worst pain, disc pain or facet joint pain? If it's facet joint pain, I think patients don't like to move their spine a lot, correct?
Well, it's a great question, Raj. I don't. So what's the worst pain? The truth is, the most common cause of back pain is the disc, by far. It is the main cause of pain. So if you ask patients, where is your worst pain, they're going to point to the disc. Even if they have facet pain, they're going to point to the disc because the disc is the worst pain. So I think the disc is the worst pain. The facet is second worst. And then the third is the piriformis muscle when it's torn, and the fourth is the sacroiliac joint. So those four causes of back pain account for 99% of chronic back pain. So if you see 100 people off the street, you don't know who they are, you just grab them. Do you have back pain? Yes. All right, come in. Those 100 people, 99 of them, the pain is coming from one of those four things: the disc, the facet, the SI joint, the piriformis, or a combination. The average patient in those patients will have four causes of pain. 4 causes. So it could be 4 discs, it could be 2 discs, 2 facets, it could be 2 discs, a facet, and an SI joint. But the point is, it's some combination of those causes. That's the average patient has 4 specific causes. So the problem is, if you only fix one cause, just one disc, for example, and you leave the other 3 causes of back pain, the patient will still have back pain. You may have gotten rid of the majority of the pain or the main cause of the pain, but they're still going to have back pain because you did not treat all 4 causes. We found in our patients, 5,000 patients with chronic back pain, that 20%, that's 1 out of 5 patients with chronic back pain, have 7 or more causes, 7 or more causes of their back pain. So if you fix 1 or 2 or 3 or 4, you're still going to leave the rest, which is 3 or 4 or 5 causes of back pain. The point is, you must diagnose all the causes during your examination of the patient. If you can, they must have their pain at the time. I ask my patients not to take their pain meds so that I can see where their pain is coming from. You must do a physical exam. Without the physical exam, you will never diagnose the source of pain. It is absolutely essential. The physical exam is the key to diagnosing back pain. And once diagnosed, the treatments are quite easy. We do them all the time. I mean, thanks. There's nothing easy about this patient's surgery. It's very, very difficult. 99.99999% of spine surgeons would never be able to do this surgery. Literally, probably 1 or 2 on earth can do what I'm doing right now. And the reason is he's so difficult to get into the L5-S1 and the L4-5. So what that does then is it really limits patients' treatment options, right? Because the patients have to go somewhere where they can get rid of their pain, but if there's only a few doctors in the world that can treat their pain properly and get rid of it, then they're going to have to find that doctor and go to that doctor and get treated. Their regular doctors near where they live will not be able to fix their problem. Someday, when the world understands how pain works in the back and the neck, once they've studied my work and they understand the source of pain, the world will be able to cure pain everywhere. You know, maybe you can even go down to the corner of the street next to the Starbucks, and there will be a back pain curing site where you can go in and get a diagnosis and get fixed. But right now, in 2024, the only place you're going to get the diagnosis right and get fixed properly is Duke Spine Institute. And that's in the entire world. That's because what we've discovered here, what I've discovered, is revolutionary. It's something that nobody else has ever discovered, and we're the only ones doing this that I'm aware of. There are other surgeons that watch this surgeries and they try to copy what we do, but many of them are in third world countries. They don't have access to the equipment that we have, and they don't have access to lasers, to laser fibers, to the scopes. So they want to do the surgery, but they can't because this equipment is very expensive to buy, and they just can't get their hands on it. All right, we're almost done with this disc. This is the right L4-5. And for those of you who watch me do surgery all the time, you know that I normally will do L4-5, L5-S1 with the same incision on the skin. It's a 7mm incision, but because the scoliosis is so severe that I was not able to do both discs with one incision. I had to do two separate incisions. And what was surprising is that the L4-5 incision was lower than the L5-S1. Normally the 5-1 is the lowest. And that's because of the scoliosis. Now, why am I making this point? I'm making this point only because there was something different about this patient than normal, and the difference is the severe scoliosis he has. That said, he does not need his scoliosis treated. We're not fusing his spine, we're not correcting his scoliosis, but we are going to get rid of his pain without touching the scoliosis. Why is that important? It's important because most people think to get rid of back pain you have to fix the scoliosis, but that's not true. I used to believe the same thing before I did laser surgery, before I did the Duke laser disc repair. I would tell my patients, you need to have a fusion done with osteotomy and deformity correction surgery and stabilization, but I was wrong at the time. I mean, I didn't know I was wrong, but I was wrong. And I've published our results. Doctors have the opportunity to come and learn the truth from us, but they choose not to. All right, any other questions?
Yes, we have a question coming from Michael on YouTube
Hi, Michael.
asking, hi, Dr. Duke.
Wow.
I
much scar tissue.
I have been watching your surgeries for a long time and really the procedure and really see the procedures you perform. I was wondering if the DLDR causes any inflammatory response.
Does our surgery cause inflammation?
Correct.
The answer is yes. Anytime you cut the human body, which we've cut the skin, it's going to cause some inflammation. Anytime you damage the human body, it's going to cause some inflammation. So we are cutting the skin. We are cutting through some material here, some soft tissue in the disc. There will be a little bit of inflammation, but not much. The amount of inflammation this patient has already is massive. And the amount of inflammation I'm creating with the surgery is far less. We're removing inflammation, so the patient will actually get better because we're taking away the net effect is to take away inflammation, if that makes sense. In other words, he has inflammation as the source of his pain. We're producing a little bit more inflammation, but we're taking away far more inflammation than we're producing, if that makes sense.
Next question coming from Raj, once more on YouTube.
Yep.
asking,
laser.
Doctor, if you have severe collapsed disc, degenerated disc with back
I
pain,
think the bag's a little too low.
does that not still warrant a fusion with a spacer or not?
Raj, the answer is no. It doesn't matter how degenerated your disc is. You can have 0 disc left, bone on bone. You do not need a fusion. Unfortunately, the surgeons have been telling everybody they need a fusion when the disc is collapsed, but it's not true. We do these surgeries every week on people with totally collapsed discs, and their pain goes away 100%, and they have a normal life, they have normal activities, they don't need a fusion. This is a myth. All right, 30 seconds on this, we're going to be done. I've done everything I can on this one, and this is the 4-5 on the right side. We're actually lucky just to get into this disc because it was so collapsed on this side. And we're going to move on to the left side at 3-4. That will be our last disc we're fixing today.
At this moment, no current questions. So in the meantime, we have shown the audience of how facets cause back pain. Why don't we show the audience how it is that we cure facet pain?
Yes, with the Duke plasma rhizotomy. That's a great idea.
Of course.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see how we treat facet joint pain. It's the simplest, safest, most effective treatment in the world. There's nothing better. And it's outpatient. It's done with our little plasma wand where we generate plasma energy to cut through the pain nerve and destroy the pain nerve so it can't grow back. Shot? That's what the RFA procedure tries to do, but it just can't do it. So the RFA wants to do what the Duke plasma rhizotomy can do, but the RFA never does that because it's just not capable of doing it. The RFA needle is too skinny, the probe is too skinny, it doesn't deliver enough energy, it will never cut through the nerve because they're not moving it. They leave it in place while they burn. We move ours, we wand ours, and that's why it cuts through. All right, we're almost done. We have one more disc to go. And our patient is snoozing comfortably with our amazing anesthesiologist, Dr. Berndes. He has not been an easy case for Dr. Berndes or me. From an anesthesia standpoint, he has sleep apnea and he's difficult with the anesthetic. The anesthetic's not working as well as we like it to, so he's having to get some additional anesthetic and maybe even some additional types of anesthesia. But he's comfortable and he's sleeping and he's doing well. He's stable. His heart and vitals are stable. And we're almost done. So we're going to wake him up soon. He'll recover for an hour and then go home. Hold on. I don't want to have another crimp. Any questions? Feel free to type up your questions. Shot, I'm happy to answer them for you. You can see the white color in front of the dilator. That white color is called vacuum space phenomena. It's a vacuum in the disc. It comes from severe degeneration of the disc, over time, and it creates like a suction, and they call it vacuum space phenomenon because the disc is under a negative pressure. And if you literally put a needle in it, you'll hear the air sucking in. We've heard that before. It's just an indication of severe degenerative disc disease. Should be good. Shot. All right, we are in. This will be our last disc that we fix. Any other questions?
At this moment, no current questions.
All right. Our next surgery will be a patient having our sacroiliac joint Duke plasma rhizotomy. She has pain in her tailbone area. She has inflammation in the SI joint, sacroiliac joint, and we're going to be going in and doing our Duke plasma rhizotomy in the SI joint. All right, why is it so blurry? Let me see. It may just be some blood from the inflammation. Let's have a laser. All right. You guys can see the laser fiber there? It's
Yes, we
1
can.
millimeter, 1 millimeter wide, 1 millimeter. So everything here in the picture that you're watching looks big. It's been magnified to look larger than it really is. That's what the endoscope does. That's what allows us to do the surgery, is that we can actually illuminate and magnify the target, which is the herniation and the tear, and we can see what we're doing inside this disc. That is unique to endoscopic spine surgery. If you're not doing endoscopic spine surgery, as a spine surgeon, you are not seeing these things. As a matter of fact, 99.9% of spine surgeons have never seen the inside of a disc. Only a few of us have, and you have to be an endoscopic spine surgeon to do that. In America, there are 5,000 spine surgeons. Half of them are neurosurgeons, half are orthopedic surgeons. And of those 5,000 spine surgeons, only 5 of them have seen the inside of a disc or perform endoscopic surgery. That's how rare it is to have an endoscopic surgeon. And the reason for that is this is a new technology. It is not yet being taught at the universities where neurosurgeons are trained and orthopedic surgeons are trained. Training for an orthopedic surgeon is 5 years plus a year of spine, so it's 6 years total. Training for a neurosurgeon is 7 years plus another year of fellowship if they choose to do it. And during those 7 years and 8 years of training, neurosurgeons and orthopedic surgeons that do spine surgery are never taught to do this surgery because their teachers don't know how to do the surgery. So who's going to teach them if their teachers don't know? More importantly, the universities now have the companies that sell screws, rods, and cages and stimulators. Those companies have representatives in the operating room that are basically encouraging surgeons to do the fusion surgeries and the laminectomies so that they can sell more of their products. And those products are screws, plates, rods, cages, artificial discs, spinal cord stimulators, barricade device, intercept device, mild procedure device. The list goes on and on. Basically, all those surgeries your surgeon are recommending are promoted by the companies that sell those devices. I got 30 seconds, maybe a minute. And the patients, unfortunately, are being the victims of this treatment that doesn't work, that's very invasive and dangerous and very expensive. If Elon Musk is out there listening, or Vivek Ramaswamy, talk to me. I can help you do your Doge job.
We have a question
Yes.
coming from Raj once more on YouTube.
Yes, Raj.
Asking, what are the post-op advice you give your patients after your procedures? Do you offer follow-up appointments after surgery?
Yes, Raj. So this type of surgery doesn't require follow-up at all. There is no need to follow up. However, if the patients want to follow up, they can. I'm happy to see them, talk to them, meet with them on Zoom. We have people that do that from time to time. 95% of our patients, we never hear from them again. They are happy, their pain is gone, and they don't want to talk to the doctor. They want to go and live life, and they do. About 5% of our patients we hear from, and they have, some pain or some other ache that they're having, and they want to know if it's related and what can be done about it. So we are always available to our patients after surgery, whether they want to come in person or they want to meet me on Zoom. I make myself available. Every one of my patients that I operate on gets my cell phone number, and they call me if they need to, and I will answer the phone and I will talk to them. And I usually cannot figure out anything on the phone, but a lot of times they want to know, when can I go back to playing pickleball or riding a bicycle or go back to the gym and exercise. So I'll answer those questions, and I make myself available to them. Okay? So there's no need for follow-up, but if my patients want to follow up, they can follow up. I don't hide from my patients like other doctors do. I'm here. I'm available. They're just doing so good they don't need me. So we're done. Great questions, Raj. Thanks for being here. And everybody, thanks for joining us. I'll show you a piece of herniation. We got one right here. Henry, can you see this?
Yes, we
I'm
can.
going to put it right. I don't know. Let's put it here. It's easier to see with the blue.
Yes, perfect.
That's just one piece. We've got many of them out. I'm happy with the results. I think he's going to feel much better. And assuming he has no facet pain and no other pain from anywhere else, just the discs, then his pain will be gone. 100% gone. Any other questions?
No current questions.
We'll be back in about 20-30 minutes with our sacroiliac joint Duke plasma rhizotomy.